Dr. Mascarenhas, can you walk us through how PV is managed and really what treatment options are available for these patients?
So PP is managed first and foremost by low-dose aspirin. The ECLAP study showed us that years ago, patients on aspirin, 81, you don't really need more than that. Some people can take it twice a day, reduces the risk of clotting. And for many patients with headaches, will improve the headaches too. Um, Patients who are higher risk, which means over the age of 60, or who've had a thrombosis or may have very significant cardiovascular disease underlying it, they may be more appropriate for cytoreductive therapy. So everyone would be appropriate for therapeutic phlebotomy, reducing the hematocrit. The goal is less than 45% as a standard. But in low-risk patients, that may be sufficient for some patients. In high-risk patients, we think that they need more than just phlebotomy. In fact, we give cytoreductive agents to remove the need for phlebotomy, and that can be anything from hydroxyurea to interferon alpha 2A, interferon alpha 2B, to ruxolitinib, to clinical trials. There are a number of clinical trials out there to evaluate novel, hopefully more effective therapies. But there are different therapies that can be used that have to be tailored and personalized to the patient to try to normalize the hematocrit or reduce the hematocrit, I should say, less than 45%. And in some patients, we're trying to normalize all the counts, the white count, the platelet count, reduce their spleen if it's enlarged, address their symptomatology. Patients who don't feel well are not going to move and eat, and the patients who don't move and eat are not going to do well. So it's addressing all of those issues. In a low-risk patient, we sometimes do use cytoreductive therapy. As we talked about with Dana, it's often interferon because that is a non-chemotherapeutic, and it does have data for addressing not just the blood counts, but potential for disease progression over time. So you really need to have a discussion with your physician about what are the goals of therapy. But the goals are uniform, reduce clotting and bleeding. But for some patients, maybe the goals are even, greater, trying to change the natural history and tendency for these diseases to progress.
Thank you. And how can patients really partner with their care team and stay engaged in really this decision making?
Patients today are a hell of a lot more informed than 20 years ago. People go on the internet, they read a lot. That's good and bad. It can sometimes lead people to wormholes where they're going in a different direction or develop a lot of anxiety from what they read that may not always pertain to their case. So my recommendation is be careful what you read. Go to sites like the MPN Research Foundation that will give you the resources that are vetted and peer reviewed, because sometimes people can read the wrong stuff and really just add to anxiety and emotion and not really get information that is important and particular for them. And then ultimately, you have to feel comfortable with your provider and the team around the provider, whether it's the nurses, the nurse practitioners, the physician assistants, that you have a team that understands what PV is and understands the need for managing the aspects of PV. And of course, I'm biased, but I would always recommend that a patient in the community sees an MPN expert at least at some point, at time of diagnosis or some point, to go over their case. And I would say most hematologists in the community are very fine with having someone see, someone who just does this in a focused way and collaborating with that person too. So I would say, go to good resources, try not to read everything. For some patients, patient support groups are really helpful. For other patients, it could add anxiety. So you have to sort of think about yourself and whether that's actually helpful or not. But you definitely need to get plugged into a care team that understands what you have and that you feel comfortable reporting your symptoms to.
Great. Thank you. Great advice. And for our last question, really, what new therapies or research developments give you really optimism about the future of PV care?
Well, anyone who knows me, I'm super optimistic about a lot of things, but particularly MPN, translational work and care. And I've seen it over the last 20 years, from an era where we didn't understand the molecular basis of the disease to an era where we now have multiple therapies and ways of measuring the outcomes of those therapies that are beneficial to patients, whether it's interferons, ruxolitinib, or agents in development like javinostat, the HDAC inhibitor, or bomedemstat, the LSD1 inhibitor. So there's a lot of targeted therapies that are built on the science that has evolved over the last decade, that makes me optimistic that we continue to head into a more targeted, more scientifically informed approach. I would like to think that in my lifetime, caring for patients with MPNs and being in this research arena, that we will have therapies that will really provide a opportunity for remission, dare I even say cure to our patients with PV. And I think we're starting to see that kind of activity. We see it with interferon in a subset of patients, even with ruxolitinib. So trying to harness that and that understanding that biology. And thankfully, we have a very collaborative community of laboratory researchers, clinical researchers, consortiums like the MPN Research Consortium that is really dedicated to allowing science drive the development and hopefully the access to better therapies for our patients.